Welcome, students. This is the final lecture for Module 104. We're going to be covering slides 72 to 81 today. We're going to be covering a few different topics for the section, which is going to be, we're going to talk about fluid therapy, IV fluid therapy, subcutaneous fluid therapy, different types of fluids. We're also going to get into caring for recumbent patients and how we should be caring for them in an ICU critical setting to avoid things like pressure sores. And then we also will, for our last subject, be covering and talking about humane euthanasia. So we will be talking about the procedure, the medications that we use, the role that assistants play, and just more about that procedure. So those are all the topics that we'll be covering for this section. So again, introductory, we're going to get into fluid therapy. But before we start on these slides and we get more into these slides, there is actually an introduction to fluids video that I'm going to be presenting to everybody here. So we're going to watch through another instructor's PowerPoint information on the intro to fluids. I really liked their PowerPoint info and it's really informative. So we're going to watch that as an introduction and then we'll come back, talk about a few slides about them, and then we'll also watch some videos about, it's linked down on this slide here, slide 77. We're also going to be going into priming a fluid bag and administering subcutaneous fluids, and I'll show you a video on how to set up a fluid pump. So all new information for those fluid therapies. Okay, give me one moment here. We'll get this started.
Hi, this is Dr. Herndon. In this video, I'm going to be talking about principles of fluid therapy in animals. What happens to a patient that won't drink? What about the patient that's losing body fluids from vomiting, diarrhea, blood loss, or polyuria? How are we going to replace this patient's fluids? How can we calculate the fluid requirements for our patients? What are some different types of fluids used in veterinary medicine? These are just some of the questions that I hope to answer with this series of videos on fluid therapy. Fluid therapy is the cornerstone of good patient care. Uses or indications in veterinary medicine include treatment of acute hypotension or low blood pressure, such as occurs with shock or hemorrhage, treatment of dehydration, which often occurs in patients that have ongoing vomiting, diarrhea, or polyuria, managing electrolyte or acid-base disturbances that often occur with certain diseases, maintaining hydration and blood pressure in hospitalized sick patients. Fluid therapy is also used in order to administer medications in hospitalized patients or patients undergoing surgical procedures or those that require ongoing administration of medications. Treatment of toxins or promoting urine output in animals with kidney disease, otherwise known as diuresis. In all cases of fluid therapy, the veterinarian is the one responsible for creating the fluid therapy plan, and the veterinary technician will institute that plan and monitor the patient. Keep in mind that fluid therapy is constantly monitored and continually reformulated according to the patient's needs. Now let's look at the body's water balance. Water is the key to our survival. The body is comprised of about 50 to 70% water, even higher in very young animals. This water is critical to proper cellular metabolism in the body. Sick animals, such as those not eating or drinking, or animals losing excess body water, such as with vomiting, diarrhea, or polyuria, need fluids replaced. Animals can live for weeks without food, but only a few days without water. When total body fluid losses are greater than fluid intake, the resulting fluid deficit becomes clinically apparent as dehydration. Now let's look at the distribution of body water. Approximately 2/3 of body water resides in the intracellular space, within the cells themselves, and about 1/3 resides in the extracellular spaces, which is then broken down into two compartments, the interstitial space or the intravascular space inside the blood vessels. If we break down the extracellular fluid distribution, We see that about 3/4 of that fluid is located in the interstitial space between the cells, and about 1/4 of the fluid resides in the vascular space or in the blood plasma. The other fluid here refers to fluids in spaces such as pleural or peritoneal fluids. It's important to mention that body fluids move back and forth freely across these compartments via semi-permeable cell membranes. Also important to mention is that increases in total body fat will decrease the relative amount of total body water, and it's important to estimate a patient's fluid needs based on lean body mass as opposed to total body weight. Now let's look at water intake and water losses in the body. How does water get into the body? Normal sources of body water include that comes from drinking and eating, and water that results from normal metabolic processes in the body. Normal body water losses result from urination, water in feces, water lost through the lungs either in regular respiration or excessively in panting in dogs, sweating, not for all species, but this is true for horses. There is a difference in the water losses. Some we can measure and some we cannot measure. A sensible loss of fluids is something that we can measure, such as urine. An insensible loss is fluid loss from the body that's not measurable. This would be something like respiratory water loss. Abnormal fluid loss results from vomiting, diarrhea, polyuria, hemorrhage, or fluid loss in body compartments, such as with ascites or effusions. When fluids are lost by any means from the body, this occurs in a specific order. Fluids are initially depleted from the intravascular space, and then secondarily from the interstitial space, and lastly from the intracellular space. The body's protective mechanism is to save cellular water until depletion rates are too great for compensation. Loss of intravascular fluid results in decreased tissue perfusion, with resulting tissue hypoxia and decreased clearance of toxins and wastes. Whole body fluid loss from the extravascular compartments results in clinical signs of dehydration in the patient. Okay, I need to define a few terms that are related to changes in body fluid volume. The first one is hypovolemia. That refers to a decrease in circulating fluid volume or decreased vascular space fluid. This is the fluid that's in the plasma. Dehydration refers to whole body fluid loss and will be assessed based on results of the physical exam and specific lab parameters. Hypervolemia refers to an excess of circulating fluid volume, such as occurs with iatrogenic fluid overload, or us giving a patient too high of a rate of fluids, or something like heart disease where the body is not able to efficiently deal with the normal body fluids. Physical exam and laboratory findings will also help us assess changes in the fluid content of the body. The way that the fluids are lost from a body often gives us an indication of underlying electrolyte disorders or an indication of underlying acid-base disorders. However, blood work is going to be necessary to confirm these suspicions. Some of the common electrolytes are potassium, sodium, and chloride that we're looking at, and then of course bicarb when we're evaluating acid-base status of the patient. We can use charts such as this example from the Wanamaker and Massey Pharmacology textbook that gives us examples of different medical conditions in animals and the expected changes in electrolytes, bicarb, and total fluid volumes. The last column contains suggested replacement fluids that we may use in these patients. In evaluating a patient for fluid therapy requirements, we take into consideration the patient's history, which may give us an indication into the type of fluid losses and the duration of these losses, the chief complaint by the owner, of course, and then the results of our physical exam. This is going to give us an idea of the need for additional testing, such as lab work, and help guide us in determining a fluid therapy plan for the patient. When evaluating a patient's hydration status, keep in mind that shock or hemorrhage will occur quickly and will cause hypovolemia and a resulting drop in blood pressure. Signs in most species include tachycardia, though we sometimes see bradycardia in cats, delayed capillary refill time, pale mucous membranes, dull mental state, and weak or even absent pulses. Severe shock or severe blood loss will decrease circulating oxygen levels with resulting organ failure, brain damage, coma, and possibly death. Dehydration, on the other hand, occurs more slowly in a patient and takes longer to correct with fluid therapy as a result. The history, physical exam, and lab work will help us assess a patient that's dehydrated, though keep in mind that the determination of the percentage dehydration is subjective, and signs of dehydration will not occur until a patient is about 5% dehydrated. When assessing a patient's hydration status in our physical exam, we're looking at skin turgor, mucous membranes, eyes, heart rate, and pulses. Charts such as this one are used to subjectively determine a patient's percentage of dehydration based on the changes in skin turgor or the increasing loss of skin elasticity, decreasing amounts of mucous membrane moisture, increasing capillary refill time, changes in the appearance of the eyes, either sunken back into the head or dry appearing cornea, and changes in the heart rate and the pulse quality. When assessing hydration in our patients, simple lab tests are very helpful. Packed cell volume, or the PCV, and the total plasma protein can be quickly performed and require only a few drops of blood. A combination of an increase in total protein and an increase in the PCV suggests intravascular dehydration. Keep in mind that pre-existing anemia may alter the results by changing the number of red blood cells, so it's recommended to always test the total protein concurrently with the PCV. A urinalysis will show an elevation in the urine-specific gravity in a dehydrated patient, though patients with underlying kidney disease that are causing the fluid deficits or the dehydration may have a lower urine-specific gravity, which may indicate the cause of the dehydration in the first place. This concludes my overview on the introduction to fluid therapy. Please take
All right, so that was it for that introduction video on fluid therapy. So we're gonna go over kind of a summary of what they were talking about in that video, and a few more details about different types of fluids. And again, we'll get into some topics like subcutaneous versus IV, and also using fluid pumps as well for IV administration. So let me get this started here, slide 72. Again, starting with fluid therapy. So, as you guys saw in that video, we give fluids to patients mainly due to dehydration. Dehydration, it could be fluid loss, which can also be due to illness. That could be due to traumatic injury and severe blood loss. It could be due to things like kidney failure, infections, certain trauma, burns, sepsis, many different causes. So most patients that come into the hospital, whether they're sick or injured, most of them will be receiving fluids in some type of a fashion. Meaning they could be getting IV fluids for a slower rehydration if they're staying in hospital, or they can get subcutaneous fluids for a outpatient procedure if they were well enough to be able to go home, but still needed a little bit of help with that rehydration. Now, we are going to be going over in the next few slides. There are a few different types of fluids. We have colloids and crystalloids. So they're the two main types of fluids that we use for fluid replacement. We can give it intravenously, right, in the vein, or IV. We can also give fluids subcutaneous, sub-Q, that's under the skin. Now, we give fluids, again, in all aspects of critical care. It's really, really important. So we'll give fluids when patients come in again, if it's trauma, if it's illness, we also give fluids to patients that are, you know, just starting to experience illness, like if they, just started vomiting or having diarrhea, any type of drastic fluid loss like that, we'd want to then replace it. We also give fluids to patients that are sedated or under anesthesia, especially inhalant anesthesia, which we will talk about in your next module, Module 105. Inhalant anesthesia can dehydrate patients while they're on it. So we always will give fluids to those surgical patients, especially if they're under anesthesia for longer than half an hour, which some procedures like spaying and neutering can be done within that time frame, but longer procedures like mask removals or dental cleanings, or foreign body removal, joint surgeries, all of those would need to absolutely have the patient on fluid therapy to prevent that dehydration from those medications, and from the procedure. So, again, most all patients that are hospitalized will be on some type of fluid therapy. And be aware that when pets are in the hospital, usually they don't want to drink water, they don't want to eat food. So we usually are supplementing them with hydration and then also supplementing them nutritionally. Now, fluid therapy will correct any fluid deficits. It'll also correct electrolyte disturbances and any acid-base imbalances. Also, when we give these fluids, we can give additional vitamins and minerals to the patient. We can even give medications through their fluid lines. So definitely a multi-purpose use. And again, we can add certain additives based off of that patient's blood work. Your doctor will run blood work on any pet that's going to be hospitalized. They'll have blood work done, and they'll do that to see if there are any of those electrolyte imbalances, so that we can add it to the fluids and rehydrate the patient properly. We don't use the same protocol for every patient. It will change and vary depending on that patient's condition, what's going on with that pet, and what is it that we're treating. Now, factors that determine that fluid therapy, as I was just saying before, what's going on with the pet, what are we treating? But we're also looking at things like how much fluids have they lost, right? We look at the volume of loss. So, how much have they lost, and how quickly are they losing fluids, the rate of loss? This is super important, especially for patients that had a traumatic injury and are facing blood loss. The doctor also will be then looking at the correct solution that will be needed to be selected for administration. So again, depending on what's going on with the pet and their blood values, they will then determine the type of fluid that we'll be giving. And we're going to look at that in the next slide. We'll look at the different types of fluids, the crystalloids versus the colloids. The doctor will also determine how much fluids, which is the volume, right? How much, and at what rate are we giving this infusion? So if they're going IV, if they're getting IV fluid therapy, they'll have an IV catheter placed, and then they'll have a connection set, an IV drip set that's connected to that fluid bag, and it'll go through a fluid machine. So that machine will control how many mLs of intravenous fluid that they're getting every hour. It's usually kilogram, um, milligram per kilogram of body weight per hour. And I teach about that in Module 102. We talk about it a little bit during Module 102 for our fluid therapies. You won't have to calculate any of that. Your doctor will tell you. They'll tell you exactly how much to give the patient for how long and if we're changing it. If it's subcutaneous, it'll be one amount under the skin for treatment. So it would be like, let's say it's a cat, we might give 100 to 200 cc's. If it's a dog, we could give up to 600. And with subcutaneous fluids, because it's going under the skin, it takes a few days for those fluids to absorb. So it takes, 48 to 72 hours, so 2 to 3 days for those fluids to really fully absorb. So it's still a slow hydration method, just like IV. We have to give smaller amounts IV because it's going directly into the bloodstream. We don't want to drown the patient out. You can cause death by adding too much water too quickly to the bloodstream. So again, the doctor will determine how much to give, where to give it, and the rate that we're giving it of that infusion. And then other things to determine is, again, patient status. What's going on with the pet? Are they critical? Are they stable? And their current condition. That will change how much we're going to give in fluid therapies. Let's break down the two main types of fluids. So crystalloids, these are the most common fluids that you're going to give, which include sodium chloride, 0.9%, which is known as NaCl. That's what we abbreviate it to. And this concentration of NaCl is close to the concentration of their blood. So it's definitely a top choice, and which is considered to be isotonic, which basically means that the solution has the same osmotic pressure as another solution. That being said, there's other types of fluids that are commonly used. So we have sodium chloride. We also have lactated ringer solution, also known as LRS. You've probably seen it in your labs. It's the most common one that you will come into contact with. It's another isotonic solution, and it's used for large volume fluid replacement. So that's why you see it mostly in those 1,000 milliliter bags. In large animals, mostly horses, our equine medicine, we use 5,000 milliliter bags. So take 5 of those 1,000s and combine them together into one big bag. They're massive, and LRS is definitely the fluid of choice with, again, those large fluid replacement. Now, plasmolite is another crystalloid. Really nice. Plasmolite is definitely a more expensive type of fluid because it closely mimics the human plasma and its content of electrolytes, the osmolality, the pH, and it does have, again, extra electrolytes in it. So it is preferable, especially in human medicine. They use it quite a bit. We still use it in animal medicine too, because it's a little bit pricier. It's a little bit harder to get as well. LRS is more than likely the most common one you're going to see and come into contact with. A colloid is a type of fluid that consists of large molecules or ultra microscopic particles of one substance that's dispersed through a second substance. Let me break that down a little bit further. So the example for this is hetastarch. That would be the one type of fluid, colloid fluid therapy that you would give small animals. So hetastarch is a fluid that increases the volume of blood plasma. So if we have a pet that has had a severe injury and lost a lot of blood volume, they would be receiving hetastarch immediately. That would be a stat order on hetastarch. We would also start a whole blood transfusion as well. So hetastarch encourages the blood volume to get replaced. It encourages plasma to also be increased to being produced. And to break it down a little bit further, whole blood consists of plasma, which is the protein, and compressed red blood cells. So in Module 106, which is diagnostic testings and procedures, I will go into this way more in depth. We'll talk about blood and the separation and what it composed of and all of that. But to give you a little gist of it, we can give whole blood transfusions, or we can just give plasma transfusions. And plasma is just the protein in the blood. Sometimes they're not necessarily deficit in those red blood cells. Sometimes we call this packed cell volume and total protein. It's a laboratory test that we run. Sometimes patients are low in total protein, but not in packed cell volume, or vice versa. So that's why we have the whole blood versus just the plasma. It really depends on that patient and their status. If it's a traumatic injury, usually we're going to be giving a whole blood transfusion. But again, hetastarch will also be something that we'll be giving the patient to help promote more production. If you don't work in emergency or ER medicine, you might never give a patient hetastarch. Again, this is really only for use in situations of traumatic and sudden blood loss. If you worked at a surgical center, you might also come into contact with it as well. Now, when giving fluid therapy, we can give it IV, and this is going to be the route that we're going to administer it when the patient is hospitalized. So when they're critically ill, severely dehydrated, if they're hypovolemic, which they talked about that in the video, but that's talking about a condition in which the liquid portion of the blood, which is the plasma, the protein, is too low. So they would be considered hypovolemic if their plasma is at a lower level. They would need a plasma transfusion, and also fluid therapy to go with it. They also might be receiving IV fluids if they're experiencing any kind of electrolyte or of a metabolic disorder, any type of imbalance that's happening there. And again, we give IV fluids through an IV catheter. Usually that's going to be in the front legs in that cephalic vein. However, an IV catheter can be placed in the hind legs in that lateral saphenous as well. Now, we do need to monitor that IV catheter. We talked about this in previous lectures. We need to be monitoring it and have eyes on it. We should be checking it almost every hour that the pet's in the hospital. We want to monitor it for phlebitis, which is that inflammation of that IV catheter site. We also need to watch for any fluid accumulation, which would be determinant of a displacement of that catheter. Both of those situations would result in us needing to pull the catheter immediately and replace it in a different arm or a different leg for our animals to then continue on that IV fluid therapy. Once we notice a catheter is being positional, it's not working, anything's wrong with it, we're going to pull it and then place a new one in a different IV catheter site. Remember, in our large animals, we're going to be placing the IV catheter in the jugular vein. So we have two choices. We can go back and forth from either or jugular vein if we needed to. And catheters can stay in for up to 7 days. They can even go past that if they're still working and it's clean and everything's good to go. But rule of thumb is right around that 7 days. But it can be sooner if it gets dirty, if it's not kept clean enough, which is our next topic of subject. That catheter bandage must be kept clean and dry. So we need to be keeping it in a good condition, because if it gets dirty and we're not changing that bandage, that's going to lead to the phlebitis. It's going to lead to the infection, which can also cause thrombosis, which is blood clotting at the catheter site, causing massive infection and trauma to that vessel. So we want to avoid all of that. And we can do that by keeping it clean, keeping it dry. Also, with the injection port on that catheter, we should be swabbing it with alcohol before flushing or injecting medications to keeping that clean. If the catheter starts to malfunction, it starts to kink, it's not working, and blood clots start to form, we need to replace it immediately. And we should be using a heparinized flush. Remember, heparin is a medication that's an anticoagulant, which means that it stops the blood from clotting. So we put this heparin in the saline solution to flush the catheter, and it prevents clots from forming in that IV catheter. If the patient's not on continuous fluids, they're at higher risk of developing clots in their catheter. So it does need to be flushed I would say every 2 hours. Some veterinarians might stretch that a little bit longer, but to be safe, every 2 hours. You could even do it every hour if they're not on constant fluids. And again, heparin is a must because it's the anticoagulant. If you're just flushing it with no heparin, there's no guarantee that a clot is not going to form. And if a clot forms, that catheter is no good. And it can cause thrombosis, which, as we know, is a really serious medical condition that can happen due to clots in the IV catheters. So, as a summary for this, regular monitoring of the patient is essential. Also, regular monitoring of their IV catheter is essential when giving fluids. And if we notice any signs of inflammation around the catheter site, we address it ASAP, because we have other sites that we can choose from. Now, what I want to go into next, before we go into our next topic, I have a few videos that are linked in your PowerPoint. I want to show you a video on giving subcutaneous fluids. This is giving fluids under the skin for patients that are outpatient, which means that they're going to go home. They're not staying in the hospital. They're sick, but not sick enough to be hospitalized. So we give them some fluids to replenish their fluids. We'll give them oral medications to go home with. And guess what? As an assistant, you'll be doing subcutaneous fluids all the time. All the time. We even have pets that come in, like cats that have kidney failure. I'll teach you more about kidney failure in Module 101, but cats with kidney failure will come into the clinic. That could be every week or every few days to get fluid replacement therapy to help keep them going in their treatment plan for their kidney failure. So it's a common thing that you're going to see. And we do it a lot for those pets that are just starting to get sick or just started to, vomit or have diarrhea and lose fluids, so we can replace it, but that they can get well at home. It's when patients are really severely dehydrated, really ill, that we have to hospitalize them and rehydrate them IV. Now, I'm also going to show you a video about using a fluid pump. I mentioned that earlier, that your doctor is going to calculate based off of the weight of the patient. They're then going to calculate how many milliliters to give every hour, and they'll give you that order. So they'll let you know, okay, put the cat in cage 2 on 12 mLs per hour. You will have to set that into the machine and set it up and get it running for that pet. So I will be showing you a video on how to use a Heska fluid pump, which is the most common fluid pumps you're going to run into in small animal medicine. We do use Heskas sometimes in large animal, but there's other pumps that we use in large animal medicine too, because we're using 5,000 milliliter bags. So it does change a little bit with large animal, but for small animal purposes, I'm going to go into, again, the first video is going to be on giving subcutaneous fluids. The second one is going to be using that Heska fluid pump, which again, you will need to learn how to use. But I will say this, these Heska fluid pumps, they're amazing. I really like them, and they're just really simple to use. They're really user friendly. The only thing is the beeping is really annoying. Like when there's an error, I swear, it's like they make the alerts on these machines really just a really annoying beep, because they want you to pay attention to it and to change it, right? They don't want it to like mix into the background. It's a very loud like beep beep. You're gonna hear it in the video. That's like the one downside to them, but it's all for a good reason. I totally understand as to why. So okay, we'll go into the first video here about sub-Q fluids, and then we'll transition into the Heska pump, and then we'll probably be right around the time for our next break. Okay, we'll get started with this one.
Hi, my name is Joni. I'm a technician here at Dove Lewis, and today we're going to talk about how to give sub-Q fluids for home administration. So here I have my lactated ringer solution, which is typically what we send home for sub-Q administration. Here I have a drip set. They're individually prepackaged and sterile. I have some gauze for drying up afterwards and a needle for administration. So to put these pieces together, just need to get everything out of its packaging. So when you take the fluids out of the bag, you want to give it a visual inspection and a good squeeze to make sure that it's not leaking fluid from anywhere. It may be a little damp from the packaging, but there should not be a significant amount of fluid or a prominent leak coming from the bag. For the drip set, I'm going to open up the bag and untangle the line. So on our drip set, there are multiple types of clamps. There is this dark blue clamp that is a sliding clamp. That is in the closed position, that is in the open position. And there is a roller clamp, which you roll with your thumb, and so that is in the closed position, and that is the open position. This is the spike end that goes into our fluid bag. So on my administration set, I'm going to clamp it, and then I'm going to pull my fluid bag off the edge of the table just so I can get access to this plug. If you pull on this plug, that is what opens up an area where you can spike the bag. You don't want to touch that area, you want to keep it nice and clean. When you go to spike, you pull off the end cap of this spike as well for the fluid set. That spike goes into this hole, and you push pretty hard to get it in there, and it should be nice and flush. So what I'm then going to do is hang my bag. So we hung the bag, but if you are at home, you can have someone help you and hold it, or you can hang it from a doorknob or a shower curtain or anything just at a height above where you are giving your sub-Q fluids. Gravity will help the fluid administration. So now I'm going to unclamp the fluids and give a little squeeze to this chamber, and you can see the fluid flowing through the line. I'm going to bleed out all of the air and out of this fluid line and clamp it off. That's just so we aren't giving any air sub-Q. We just want to make sure that it's fluid. So I clamped off my line now that it's completely bled through and there is no more air. I'm now going to put my needle on. To do that, there is a little cap at the end of the drip set. You can give a nice twist and get that open. This part is, again, sterile. You don't want to touch it. I'm going to do the same with my needle, and that gives me another sterile area. These two fit together, and then there is a twist to lock it into place. Now that my fluid administration set is set up, we're actually going to give the sub-Q fluids. The best place for that is right here in between the shoulder blades. This area tends to have a lot of extra loose skin and can easily tolerate a lot of sub-Q fluids put in one location. Since this kitty's a little bit nervous, we're just going to use a towel to cover his head and make him a little bit more comfortable. Sometimes with some more anxious animals or at home, you can burrito wrap the patient in a towel if it makes them more comfortable that way. But you just want to make sure you're still able to access this area in between the shoulder blades. So what I'm going to do is lift up the skin, and it's going to make a nice tent here. And if you imagine my finger was the needle, I am going to go into that tent right in between my fingers so that I'm not poking myself and I'm going straight through the skin. So it's really easy to feel where you're going to go and visualize. Now what I'm going to do is take the cap off my needle and try and aim it bevel up. The little angle on the needle is going to face up. When I lift up his skin, I'm going to find that tent shape with my finger, and then I'm going to poke in there with the needle. You should feel it just have a little bit of tension when you go through the skin, and then it should feel easy after that, and that's how you know you're in place. What I then do is unclamp the fluid line, and you should be able to start seeing the fluids dripping in the chamber of the fluid line. If you see fluid dripping out around your needle or fluid dripping out around the skin, it can mean that you have poked completely through to the other side of the skin, which just means you need to reposition your needle. Sometimes you can also position your needle a little bit better in the skin so that the line flows a little bit easier. It's also acceptable to put pressure on the fluids. So that means you just give the bag a little bit of a squeeze, and you can see that the fluid goes through faster. Some animals get anxious at this. It feels cold and they can feel their skin stretching out and they don't tolerate it as well. But this kitty is doing pretty well with the fluids going pretty fast. So with the bag free hanging, you can see that this 1,000 ml bag has markers down the side that divide 100 mils. So since this kitty is going to be getting 100 mils of fluid, we need this fluid line to get down to the 100. If you're holding the bag, it can change how it looks, but so you want to make sure that it's hanging when you're looking. If you are going to squeeze the bag, you do need to check periodically to make sure that you are not going past how much fluid the kitty is supposed to be getting. Okay. So it looks like I'm just about at 100 mils. So I'm going to again clamp off this line so that the fluid stops dripping. And you can see a fluid pocket has gone under the skin here. They kind of get a camel hump there that is where the fluids go. It's not painful and it'll just absorb as they need it. So what I'm going to do is put gauze over where the needle comes out and just put a tiny bit of pressure while I pull the needle out. So with the needle, you want to put the cap back on, not towards your hand, but against a table. We generally here leave the dirty needle on the bag of fluids so that we know each time we go to give fluids, we put a new needle on. And don't trust that the one there is clean for you. So now, where I gave this sub-Q fluids, we have been holding a little bit of pressure with some gauze, and you can see that she's no longer leaking fluid. If she were to leak fluid out of there, it could be a little blood tinged. That is completely normal, but you just want to make sure as much of it stays inside of her as possible. So that is how we administer sub-Q fluids in a cat.
Okay, wonderful. So that was the subcutaneous fluids video for the fluid therapy section. We're now going to go into the second video, which is setting up that Heska fluid pump that I was talking about. So we'll go through this. And again, really important to be focusing on this, even taking a little notes on it, because this is something you absolutely will be doing often, especially if you work in emergency medicine or any hospital that hospitalizes animals and does internal medicine. Okay, we'll get started with this one. And again, this is for IV fluid administration.
Okay, I want to show you how to set up the fluid pump. And a fluid pump is a great thing to have in a practice. It really helps when you only have 1 or 2 technicians, so that you can really keep a good watch on the fluids that you're giving your animals. When you're not using a fluid pump, you can set the drip rate, say at 10 drips per second, or 10 drips per 10 seconds, and then the animal can move its leg, and now for some reason you may only be giving 5 drops per 10 seconds, or you may even be giving 20 drops per 10 seconds. So you're either giving not enough or too much. So this is a great way to utilize your technician time and for safety of the animal if you're using a pump. So I have my fluid set up here. I have my fluid bag that I have sterilely attached to my fluid line here. Once I took the top off of this and set the line into this port right here, okay, then I flipped it upside down and I let the water flow through all the fluid, flow all the way through the line, okay? And then once the line had fluid all the way through it and didn't have any air bubbles in it, I clamped it closed. Okay. So now I'm going to set up my machine. So when you look at this machine, this is a Heska. Some clinics have other machines, so they're going to be set up slightly different. Your clinic will teach you how to use theirs if it's not a Heska. If you push this button here, it opens up. It has directions. It says flow direction right here. Basically what flow direction is which way you want the fluids to flow. So I want the fluids to flow from left to right. So this bag is going to go, this fluid line is going to go through here. Okay. And I'm going to set it in here. Now that it's in and this is closed, you can actually open this clamp back up. So you can open the fluid line. I find it's important for me to open this back up, because otherwise when I start the fluids, if they're attached to the animal and I've forgotten to open this, usually I get a high pressure sign, which means that there's high pressure and you might have left a clamp open or closed. So now to turn it on, you hit the on button here. Machine's going to light up. It's going to tell you a bunch of stuff. Right now it's set at 0. Over here on this side, this says macro, T-P, TPN, and MIC. This is how you set your fluid drip rate based on the size of the fluid line that you're using. This one right here is a macro, so we're going to have it on macro, but you can change it depending on the size of the line you have, and I'm going to show you how to do that right now. So you turn off the machine. Once you turn off the machine, you push select over here, and then you push the on-off button. Okay? Up. Let's try that again. Select. And then it'll say select here. Once it says select, you can let go of the buttons, and then you just hit select to pick where you want. So over here, it's now at MIC. This MIC is a micro drip line, so it would be a 60 drop set. So if you started off using a 60 drop set in an animal and then decided you had a fluid pump available and you wanted to switch it, you would need to make sure that you switched it on the fluid pump. This is the 10-P, here's the TPN, and then there's another one that's called an easy TPN. Okay, I'm going to set it back up to micro or macro because that is the size tubing that we've used here. And then I'm going to hit off and turn it off. Now I'm going to turn it back on. Okay, again, it's set to macro here. And over here it says rate. So when it says rate, this is how many mLs you want to go per per hour. So we're going to say this patient needs 52 drops per hour. So you push the up and down here, arrows. When you hold it for a little bit, it'll eventually click on. Okay, so 52 drops per hour is what or 52 mLs per hour is what we're giving. Then you're going to hit select again, and this is going to go to time. I'm not going to put a time in here right now, but you could put a time in here if you wanted it to calculate your volume to be infused. So say the doctor said give 52 mLs per hour for the next 5 hours. You could just put in 5 hours here. Okay, and then if you hit select again, it'll tell you how much fluid needs to be infused. So it's actually gonna infuse 260 mLs over those 5 hours. So that's an easy way to do it if the doctor just says give, you know, this many mLs per hour for the next 5 hours. Good way to do it without having to do some calculation. But we're gonna say we're gonna calculate it. So I'm gonna hit clear here, and I'm gonna say the doctor wants us to give 200 mLs total. So this is how many he wants total, or she wants. Okay, and please notice once it went over 100, it goes up in increments of 10. So if you need to give 193, you might as well go to 190. If they want you to give 195 or 96, go up to 200. So here's our 200. Then I'm going to hit select again. This VI here is volume infused. Right now we haven't infused anything, so it should be 0. So if you click VI and there's a number here, you want to hit clear. Okay, so now it's all set. I just want to show you how the time changed here. So we're going to infuse 52 mLs per hour, and we want to do 200 mLs. So it's actually calculated at the time. So it's going to take almost 4 hours for those 200 mLs to be infused. So this is a great way to check to make sure it makes sense. So now that that's done, I can go ahead and hit run hold here, and it's going to start. Okay, so now it's running. I just want to show you what's going to happen when it's high pressure. I've closed off this clamp. So this is in a few seconds, it should be giving me a high pressure sign. So it says high pressure, it's going to yell at you and say high pressure. So that means that something's going on. You need to either check your clamp to make sure you've opened it, or check the patient. If the catheter is positional, you'll need to check that. So if you have any questions, please let me know.
Okay, so that was it for that video on the Heska fluid pump. So that concludes our section on fluid therapy for the lecture. We still have 2 more topics that we're going to be covering, but before we do, we are going to go on a break, so I am going to pause the recording here. Okay, welcome back from the break, students. We're going to keep on continuing with the PowerPoint information for this section. So we're now going to get into nursing care for recumbent patients. So in nursing care, right? If we have a patient that's critically ill or traumatically injured, it is possible that they might not be able to walk or really freely move that much during their recovery, especially in the early stages. So these patients, we might be putting them into a lateral recumbency or a sternal recumbency while they're healing in the hospital. Unfortunately, with recumbent patients, the primary concern for these patients is the formation of decuboidal ulcers. And these are essentially pressure sores that can form. And in this picture up here in the upper right-hand corner, where the red circles are on this diagram, those are commonly where pressure sores develop. So it's, you know, we're talking about the elbows, the shoulders, the hip, the stifle, and even below the eye socket, right on that kind of bony place, cheekbone area. So with that being said, we do a lot of preventative measures to stop this from happening. And we'll talk about that in the next slide. But to address here, what you're looking at is you're looking at patients that are laying down, again, lateral on their side, it could be left or right, or sternal on their stomach, and they're going to be supported as they're laying down. Unfortunately, these pressure sores, they develop rapidly. So they develop really quickly and it takes them a long time to heal. And we grade them from grade 1 to least severe to grade 4, which is the most severe. So with that being said, grade 1 through the first grade 1 and 2, that's like where we would use things like donut bandages. We could use foam pads to create some extra distance. We might even use topical astringents. And astringent is a chemical that shrinks or constricts body tissues. So usually in this situation, we would apply an astringent lotion to the skin to help reduce bleeding that can be caused by minor abrasions, or in this example, decuboidal ulcers. So an example of a topical astringent would be like things like calamine lotion or even like Neutrogena can be considered that. So it's basically like a barrier. We also can administer antibiotics if we need to, because these pressure sores, if untreated, absolutely can become infected as well. Now, when it gets a little bit more serious, we may need to do surgical intervention, which means the doctors would actually have to operate on that area and remove them. And that's if, it's just severe, we're unable to get it under control. We've tried treatments, but it just keeps getting worse. And usually, as kind of expected, if the patient is laying down on their side or on their stomach, even if we're rotating them every 2 hours, they can still develop these sores. And if they're not getting well to a point where they're getting up and they're starting to relieve pressure on those sores, it's really hard to heal from. So it's hard to heal patients that are still in the recumbent positionings that are putting pressure on then those wounds. Now, prevention methods is to keep the patients clean and dry. So these patients that are in these recumbent positions, they're not getting up to go to use the lawn to relieve themselves, right? Or they're not going to get up and use a potty pad. They are going to urinate and defecate right there as they're laying down, which means that they're more than likely urinating and defecating on themselves, especially if it's a male, because the males, their penis goes right underneath their ventral abdomen, right? So if they're urinating, that's going to go all over their abdomen, their legs. And of course, defecating, especially if they're having things like diarrhea, can also pose an issue. Now, they can place urinary catheters for bladder maintenance. They usually will catheterize, especially if they're male. Females, their urethra, it exits right below where the anus is. So it's generally not that big of an issue with our females because, again, it's not all over their abdomen like where the males are positioned for that. So we can place a urinary catheter while they're in this recumbent position. For bladder maintenance. We might even have to do some bowel maintenance too, which means that sometimes these patients are more than likely going to have it can be kind of two ends of the spectrum here. They're either going to have diarrhea or they're going to be constipated is usually what we see. And it usually has to do with things like dehydration and not moving around and not stimulating their guts. So they're not working as well as they should be. So we do have to monitor for that. But of course, because again, they're laying down, they're unable to get up, they're going to be soiling themselves. So a huge part of caring for them is making sure that they're clean and dry, constantly changing their bedding, constantly changing the padding. We might even use disposable diapers. Again, a urinary catheter is an option as well. We'll also be using the puppy pads and all of that to place all around them. Because if they're urinating or defecating on themselves, it can easily cause an infection. Urine actually contains ammonia, and ammonia can burn the skin if it's left on the skin. So we do need to be cleaning them as gently as possible as well to try to prevent any infection from happening and any burns on the skin as well. Now, we do need to be turning the patients. So if they're in lateral recumbency, we're going to turn them from left lateral to right lateral, and we're going to turn them every 2 to 4 hours. Closer to 2 hours is better. I'd rather turn the patient more often than wait too long and then a pressure sore develop. Pressure sores happen when they're in that recumbency for too long. So I recommend every 2 hours. You can stretch it. But again, if we're trying to avoid those decuboidal ulcers, we're going to want to do it more often. The main goal is to get these patients well enough to, of course, get back on their paws and be walking and operating as normal. This would be, again, for really critical care patients, severe injuries, severe illness. We even have recumbent foals. So in large animal medicine, um, sometimes the baby horses are born with illnesses or abnormalities. We even have it's called dummy foal syndrome, where they're born and they can't really walk and they don't really understand quite on how to operate themselves yet. Most foals do grow out of it, but they can be recumbent for several days after birth. And so we will do the same thing for horses. We'll place them in a stall right next to their mom, and we'll have a little cornered off portion of the stall for them, and we'll put them on a padding just like this and flip them over back and forth because foals, they weigh anywhere, they're usually around 250, 200 to 300 pounds. It kind of depends right in there. So with two people, you could two or three, you could definitely be flipping a foal back and forth. Sometimes they weigh a little less. It kind of depends. But we can do this same kind of recumbent care for them too. All right, so our last subject for this evening, we are going to talk about humane euthanasia. And I say humane euthanasia because if you didn't know, euthanasia actually stems from the Greek language and it actually stands for good death. That's right, good or humane death. The euthanasia process is to provide a quick and painless death with minimum stress and anxiety. So that's exactly what that term translates to in Greek. Now, I want you to be aware of this. I know that euthanasia can be a hard subject to talk about, right? This is the ending life stages for our animals. Remember this. We're there for the animals in their entire life stages. We're there for them in their first puppy, first kitten exam. And we're also there for them during the end of life stages when then they're going to cross over that rainbow bridge. It is a part of our job. You will never get away from it. It is something that can feel very uncomfortable. I would like to give you a little bit of comfort around this topic. I don't want to be the person to say, like, oh, you'll get used to it or oh, it gets better. In all honesty, you learn how to deal with it better. You learn how to regulate yourself and you learn how to be there for the owners. Remember, yes, we are working with animals. Yes, we are doing, helping with this procedure. Yes, it is sad. But I try not to view it as completely sad because it's not all the way. And hear me out, hear me out. Again, euthanasia is to end suffering. We only perform euthanasias on animals where their quality of life is poor and the bad outweighs the good. Doctors will do, it's called a quality of life exam. So if an owner wants their animal to be euthanized, if we've never seen them before, or even if they are patients at the clinic that we're working at, we will still do a quality of life exam. So you're going to check them in just like normal, right? You're going to weigh them, check them in, get a little bit of history, place that in your soap notes, and then the doctor will go in and perform a quality of life exam. And they'll ask questions to the owner to see what's going on with the pet, their medical conditions, the treatments that they've done. And if the doctor determines that the animal's quality of life, again, the bad outweighs the good, it is up to their discretion if they believe that that euthanasia is an adequate option for them. We do not take this lightly, and we are not euthanizing healthy animals by any means, especially in a private practice type setting. Now, I can't say the same thing for shelter medicine because there has been history of shelters euthanizing in the past because of overpopulation and things like that. I will say that it's been different like post-pandemic because there was so much pet ownership. There was a boom in the pet ownership from the pandemic, which I think is great. So I have not seen so much of the overcrowding like we used to pre-pandemic to where that's a thing. But do know that if you work in shelter medicine, their protocols around euthanasia may be a little bit different. For example, in shelter medicine, if an animal were to come in and they have a life-threatening illness where it's going to take thousands of dollars to get them back to a well state again, a shelter is going to look at quantity of patients. They can save so many animals with $5,000 versus saving just one. So a shelter will save the greater good. So they do tend to euthanize more often. Again, that's also because no one's paying for these treatments, right? They're nonprofits. They pay for animal treatments through donations, and volunteerism and stuff. And so it is different in that world of medicine. I will preface that. However, again, it goes back to serving that greater good and serving that population, that bigger population of homeless pets. Rather than spending all that money for just saving one, they can save many. And that's kind of the concept there. But again, it's changed drastically since the pandemic, changed a lot. In private practice, again, the doctor will do a quality of life exam and will determine if that patient is a candidate for euthanasia or not. Now, with euthanasia, we use specific medications. We'll either be using Euthazol, or it's called Fatal Plus is another one. And this medication will produce rapid loss of consciousness and then death. Be aware that we sedate the pets before we give this euthanasia agent. We sedate them usually with Tilazol before we give it, just to have them nice and calm and relaxed. And this, again, euthanasia doesn't cause pain. It doesn't cause distress. It doesn't cause anxiety. They quite literally just go to sleep. That's why a lot of people say, putting the animal to sleep, because that's what the procedure looks like, and that's how the animal will feel. They're not going to feel pain. It's not going to be a sudden, painful, scary death. It's very calm. It's painless. It's actually, I think, is a really beautiful thing. I think that it's wonderful that owners can say goodbye to their animals in an environment like that, and they can know that their animal will no longer be suffering anymore. I think it's such a service that we can provide for pet owners. If you think about it, we're only going to be euthanizing animals that have chronic health conditions where they're terminally ill, like cancer patients, for example, or traumatic injury. They're not going to be able to survive from it. So in emergency medicine, you may see an increase in euthanasia because, of course, if a dog comes in and they're hit by a car and the injuries are too drastic and we cannot save them, we will go forward with the euthanasia procedure. That's going to be the fairest way for that animal to cross that rainbow bridge, right? Rather than wake them up from surgery, having them be in horrible pain and dozed out on drugs until they naturally die. That sounds like a terrible death. It sounds terrible. Which is why euthanasia is that option. My preference, I believe that it absolutely is the better option. And of course, everyone's entitled their own opinion about it. But remember, it's something that we do a lot in the field, and it's justified. It's justified. It's going to be performed by the veterinarian that you're working with. And they will, again, after performing that quality of life exam, you will assist them, meaning that you'll help we place IV catheters in animals that we do euthanasia procedures on. Sometimes we'll do an inhalation method if it's a pocket animal, or maybe the veins are just, maybe they were just so sick and the veins are so decrepit that we can't place anything in them. We can use the inhalation method. Most doctors will avoid IP or ICs, or only do it if we absolutely have to. An IP injection is when we go into the abdomen. An IC is an intracardiac when they go right into the heart. Again, those would only be done in very specific circumstances by a veterinarian. And actually be aware, for all of this, you will never be the one administering Euthazol. Okay, the only person that's licensed to do that is a veterinarian. So you will never be the one giving it. You'll probably not be in the room for it either. Most of the time, we're checking in the patient, we're placing the catheter, the doctor does the exam, and then we'll pull up the solution and the doctor will go in and do the procedure. However, assistants do play a really important role for afterwards. We do let the owners grieve. They can take as much time as they want in the exam room. And once they're finished, once they leave, I don't know much about the state of California if they let, it really depends on where you live. If you live in a place where they allow you to bury animals on your property, you could take your pet home with you for a home burial. Where I grew up in Washington, we buried all of our animals on our property. I lived on a farm, my parents' farm. And so it was a little different. If you live in a place where you cannot bury your animal, then cremation is going to be the other option for their remains. We do communal cremation and we do private cremation. Communal cremation is where they would just get cremated with other animals and you do not get the ashes back. Private cremation is when you pay more money to have your pet privately cremated and they will return the ashes back to you and you will also pick an urn for your animal. It's usually a few $100s for the private cremation and it does vary by weight. So a Chihuahua, right, a 5-pound dog versus a Great Dane, 100-pound dog, there will be a significant price difference there to be aware of. And it's the owner's discretion on what they would like to do. Now, what we do as assistants is, again, once the owners have left, we will go into that exam room and we will collect the patient. And we will be usually collecting once we take the patient from the room, we'll usually collect a hair sample for a shadow box. Your hospital might do a nose impression. Most commonly, we do paw print impressions. And let me just show you a quick visual of what that looks like. So you may have, if you've ever had an animal pass before, you may have received one of these before. They're called paw prints. These are common kits that we use in the field. I've used this exact kit very numerous of times. We do this once the animal is deceased. Again, we'll take them out of the exam room and we will prep the clay and get it all ready. We will trim the nails on the paw so that sometimes they're a little long. So we'll trim them back so that they don't poke through the clay. And then we'll press them down into the clay to give a nice impression of that paw. You might even do multiple. I've had patients where, it was the family dog and I did 6 paw prints for one dog because all of this, all of the kids wanted a paw print and so did the parents. And so you may do multiple. This is such a beautiful keepsake, such a beautiful tribute to that animal and to their life. Again, I know that this can be a hard topic to talk about. I know that it is a sad topic to talk about, but one thing that helped me with dealing with euthanasia was doing these paw prints. I lost, I grew up on a farm, you guys. I have dealt with animals in veterinary care and euthanasia quite a bit throughout my life. And one of the most comforting things was receiving a paw print or receiving my pet's hair back or getting a shadow box. And so when I started working in the field and I was like, man, euthanasia is hard. This is they're saying goodbye to their fur baby. This is a hard thing to talk about. I would put all my effort into that paw print because I knew what it felt like to get one back. I knew what it felt like to have that closure, to have that piece of my pet that I had lost. And so I encourage you to find outlets like that. Instead of focusing on the owners and again, their loss, I focus on what a great life that animal must have had and how I get to pay tribute to their life by creating a beautiful keepsake for those owners to take home and to have forever. I get to be a part of that story. And it's my responsibility to make sure it's the most beautiful paw print they've ever seen in their life. Guys, I would sit down and take 30 minutes to do one paw print because I wanted it to be so perfect, because I knew how much it meant to me. You can even put charms on them. I've worked at hospitals that had stamps, so you could put the patient's name on them. Again, it's really beautiful. And it really helped me be able to feel like I was giving back in a way. And also, again, honoring that pet and paying tribute to that pet's life and giving the owners a little bit of closure. So I encourage you to try to step away from that mindset where it's, scared and sad. I encourage you to step into that empowering mindset and remember that, again, euthanasia, it stands for good death or to die well. This death is not going to be something that is not going to be well intentioned. And again, I encourage you to look at the tribute to that animal's life. A lot of owners will react differently to euthanasia. We do talk about this in some other modules, but owners will act in all sorts of different ways. If they're expecting it, some owners, you'll see some owners that are very expressive with their emotions. You'll see others that aren't, they've been expecting it or they know that it's been coming. You'll see some owners that want to be with their animals. You'll see others that won't be able to. It is a different process every single time that you do it. But remember, you're there for that animal and you're there to make these last moments in their life comfortable and calm and loved. That's what we're there for. So that is everything that I wanted to talk about for this evening. We are officially done with chapter 6. With that being said, I am going to end the recording for this PowerPoint for Module 104.